Welcome everyone to this presentation on full arch therapy. Today we're going to be discussing FP1 to FP3 prostheses. I had the pleasure of doing this presentation at the Neodent Symposium and XP presentation this year dealing on implant complications. I think this is a very relevant topic in 2024-2025. So I'm happy to be giving this lecture also on YouTube for those people that could not attend in person. A little bit about myself. I am a practicing clinician just outside of Toronto, Canada. Been practicing for the last 15 years. Most recently, I had the pleasure of contributing a chapter to the Modern Implant Dentistry textbook. The focus on that is on socket shield partial extraction therapy. Some of the concepts you'll see in this presentation discussing single teeth to full arch are included in this chapter. In chapter 25, I'd highly recommend to check out this textbook. It became a bestseller last year, and it involves a lot of great authors and topics relevant to implant dentistry. And as well as a matter of fact, I'm not just a practicing clinician, I'm also an educator. So the Canadian Implant Dentistry Network is something that's a passion of mine, developed over 7 years ago. And our goal with the Canadian Implant Dentistry Network is to bring educators from throughout different parts of the world to come to Toronto, Canada, and educate doctors on their areas of expertise. Over the years, we've had Dr. Maurice Salama, Dr. Sher, Dr. Ihab Musa, Dr. Ricardo Kern, a number of educators that have come and trained doctors at our facility. Most recently, last year, we've developed the Canadian Implant Dentistry Network education facility, and with that we're able to bring our laboratory, our training facility, and everything that we do in implant dentistry to one location. The importance of that is that we can now provide A to Z training for those doctors who are involved with the Canadian Implant Dentistry Network, not just surgical training but also prosthetic and lab expertise from our on-site laboratory. And for me, finding your passion in implant dentistry is not a one-person effort. It always involves a team behind you. Luckily for me, my wife is a dentist as well. She's practicing alongside with me. I always joke around that I went through dental school twice. Once when she graduated, she was 3 years behind me, and once when I graduated. Here in this lovely photo, you can see I'm helping her sort through endo teeth that we had to collect as part of her requirements back in our balcony in London, Ontario. And out of those, dental bonds that you develop, sometimes good things happen beyond dentistry. So we have two lovely kids, Jason and Emily, who are now 8 and 10 years old. So today we're going to be discussing a decision tree algorithm for planning your cases from FP1 to FP3. We're going to discuss emerging trends in partial extraction therapy, how to apply that in full arch. We're going to talk about digital smile design, how to look at these kinds of cases from a prosthetic endpoint to avoid complications in terms of case planning and to develop something that is not just aesthetic but also functional for your patients. For us, in terms of digital workflow, we've been in digital dentistry for almost coming up to 14 years now. We have a team of on-site technicians, now a team of 6 technicians since this presentation was made. And the goal with that is to not just provide services for us, but also for clinicians throughout the US and Canada. It can involve things as simple as a single tooth implant crown, all the way to complex full arch case planning that may involve a team effort and some hand-holding at the start for clinicians just starting out. And for us, when we say digital dentistry, why is that something that is important in 2025? Number one, precision of our cases. Secondly, efficiency. You can be faster in terms of the actual surgical procedure because you've already planned it behind the scenes. And third, most importantly, is patient satisfaction. So all that planning that you do behind the scenes helps to deliver a seamless process, hopefully, in the operatory so that you can deliver something and that is going to be a favorable outcome for your patients. But behind the number of screws that goes in the mouth, behind all the planning, end of the day are patient stories. Patients don't care if you have 4 implants, 6 implants, 8 implants. They want teeth. So end of the day, it's about the smile. But in order to get there and have those outcomes, we need to plan these cases properly. So for us, how do we do that? I think a big part of that is digital dentistry, because digital levels, as a clinician who's confused on where to start off in digital dentistry, can be overwhelming. So I always recommend to clinicians to begin with high-end photographs of their cases. Why? Because that will dictate your treatment planning in terms of smile aesthetics, in terms of transition zone, and hopefully having a favorable outcome. This transitions all the way to level 7, which is milling, and although that is a more complex procedure, not necessarily achievable in every clinician's office, I can tell you for us, we were milling single tooth crowns for a number of years before we transitioned to implants. But understanding where you are on the spectrum of digital levels helps you to understand your workflow process and eventually potentially your end goal as somebody who is involved further in digital dentistry. So depending on which level you're at, it's important to understand that. Most recently, we've started to use something called Smile Cloud. This is a newer development in process. It allows you to upload high quality photographs of your cases, allows you to choose an AI library of options based on that photo, and based on that smile design, imports a 2D photo into the software, and then you're allowed to export a 3D version of that smile design that can now be used in aesthetic mockups and also smile design in software such as Exocad. But behind the ability to do a smile design, you also have to deliver. So in this case, the patient was very happy with the outcome. We were able to deliver something that matches the aesthetics of what she has seen in the preview design. Next, we look at digital design of our cases and what are the tools that we use to help convey that information to our laboratory. So for us, it always begins with data acquisition, taking either impressions in analog or digital scans of our patients, taking CBCT records. This next gets imported to virtual planning and implant selection software such as co-diagnostics, then surgical guide fabrication and the actual surgical procedure itself. Common tools that we use in our practice include Trios 345, an excellent scanner able to capture bloody fields, able to capture data seamlessly, and it's also very easy to use in terms of the software, in terms of the layout of the information that is present. Next, we bring in that data into co-diagnostics, which is one of the tools that we use for implant planning software in our office. Finally, we're able to 3D print. 3D printing has been a game changer in our practice. We're able to take that data, bring it into our 3D printer, and allow for same-day dentistry. So that has been a game changer in terms of what we can deliver with patients waiting in the chair and having temporization on the same day. And guided surgery, as we talked about, that not only increases the accuracy of your cases, but also brings down surgical time and patient discomfort, with the end goal being preventing complications by planning of your cases. And complications can happen in single teeth and also full arch cases. But before we jump into full arch, it's important to understand that the complications that we deal with in single teeth get magnified in full arch. So let's look at single teeth first. So for a single tooth, how do you deal with these kinds of complications? It can be a challenge. Either implants are placed too facially, maybe the implant diameters were too large, maybe the tissue has receded with time. How do you deal with these kinds of situations? So in the aesthetic zone, a lot of the time when you've placed implants in immediate cases, and you take a CT scan by chance on your cases, or maybe the patient's symptomatic, if you take a CT scan, it looks like these implants were placed incorrectly, meaning they're outside of the bony housing. But what happened in the medium term is that thin facial plate has resorbed, either from muscle tension or just from natural resorption that happens in cases in where you've done an extraction. And what do we do as clinicians? Normally we're placing our implants paddle, placing it deeper, using a narrower implants, and compensating for that shrinkage with biomaterials in the gap, and tissue compensation in front of that, either with a connective tissue graft harvested from the tuberosity or from the palate. Now that adds an increased morbidity factor. It's painful, but also cost for the patient. So we need to understand, for these cases, management may involve not just your implant placement, but also additional procedures. A very nice article which I saw last year, which was a decision tree on single dental implants from the team at the University of Michigan, looked at cases and in terms of soft tissue deficiency, broken down to a number of categories, either being a surgical basically a surgical solution to the case, or a prosthetic solution, or sometimes combination, or sometimes it involves removal of that implant entirely. So in cases in which you are able to simply remove the crown and change the abutment shape, that may be sufficient in terms of getting that implant in a more favorable position prosthetically. So you can't change the implant position, but at least at the abutment level, the abutment can be modified to bring that implant crown further in from the facial aspect. Sometimes, though, it may involve tissue grafting in addition to that. In those cases, we're relying on tissue to mask and correct those problems. In addition to that, sometimes those implant crowns have to have not just soft tissue augmentation, we have to do a surgical and prosthetic solution in terms of taking care of the area. And in some cases, the implant could be completely out of the bony housing. So all those kinds of solutions will not be sufficient. You may have to actually remove the implant. Why is this important to understand? Dealing with single tooth failures, again, gets magnified when you're dealing with full arch. Let's look at first at one example. Us as clinicians, we need to avoid pulling teeth immediately and not thinking about the long-term outcomes. So here I had a patient who was actually a hygienist, very young woman, had trauma very early on in her life and had avulsed her two central incisors. They were replanted. Over time, they started to ankylose. They started to have resorption on them both. When you took the CT scan, you can see the shape of the area has an hourglass defect, meaning that immediate implants will be very challenging because of the undercuts present. However, a hopeless tooth is not a useless tooth, which is coined by Dr. Salama and Henry Salama from an article in IJPRD. And you can see here, even though the one central has completely resorbed at the root level, the other one still has some favorable elements. So what can we do in this kind of case? We don't just go and pull the tooth entirely, knowing the consequence of resorption. We end up performing what we call a socket shield procedure. In this case, because there's not good bone to anchor the implant into, we do a modified version of that, which is called the Glocker approach. So in this case, we go ahead and perform socket shield therapy, wrapping around the line angles in order to get increased surface area and retention of that shortened root. And partial extraction therapy has been a game changer in my private practice. Used over the last 8 to 9 years in private practice, allows us to preserve the facial plate and contours with great predictability. And as part of the PET research group, I'm happy to be able to bring these kinds of unique situations into applications in full arch. As one of the Canadian doctors in this group, I'm also very proud of that fact as well. So in this case, we go ahead and graft the case. This is a mix of cortical cancellous bone mix. And 4 months later, we will take a new CT scan on the area. After re-entry, you can see you have abundant tissue volume. And when we re-enter it, we plan a case, plan at our laboratory and guide that is made to get the implants in the exact position. And we temporize the patient. Now we don't go through one temporary only. We might have to go through a number of temporaries. That's where digital dentistry shines. So in this case, we have temporary 1. We can see we need to push the margin apically. In that case, we need to increase the pressure on the temporary in that apical region. That will push the tissue apically in order to push the margin up. And then we communicate those changes to the lab by digitally scanning not just our crowns, but also the shape of the tissue. This is where clinicians could make an error and assume this is sufficient. I'll send the case to the lab at this stage. This would be a mistake. You need to develop the tissue so that you have predictable outcomes. So in this case, we're starting with a flat tissue profile, ending with thick, abundant tissue of the right shape and size. That we can scan and communicate to the lab and deliver a seamless insert. There's no more painful inserts at visits. Why? Because you've developed the tissue on your patients. And why do I show this case before jumping into full arch? It's because we need to take the time to not rush our cases. You'll see in social media sometimes clinicians and doctors at courses are promoting teeth in 24 hours or teeth in 2 visits. If you go fast, sometimes you will not be able to achieve the aesthetic results that you want. So slow down, take the time to develop the case and the tissue most importantly. How about full arch treatment options? What about if a patient comes in and they have a high smile line, or if they're a patient with periodontal disease? Would you treat these patients in the same manner if they came into your office? And the answer should be no. Unfortunately, sometimes these get boxed into the same cookie cutter approach in which bone reduction is performed and what we call an FP3 prosthesis, which is a hybrid prosthesis involving replacing the gingival tissue and the crown portion, is performed. A lot of these cases which come in as cases involving decay may not necessarily need that bone reduction. And what I've done is I've broken down this approach into a full arch algorithm. And it simply involves breaking down the patient's etiology into either periodontal disease or decay wear patients. So let's look first at periodontal disease or edentulous patients. So if a patient comes in, the teeth are mobile or loose or they're edentulous, what you need to do is take high-end photographs, meaning having the patient at maximum smile and evaluating if the bone level is sufficiently below the lip line. If the bone level is sufficiently below the lip line, such as here, we need to look at the bone width next. So that involves bringing in your data into your planning software and looking if you have sufficient width for the implants you're going to place. If you do not, that's when alveoplasty is going to be recommended, so that you have at least 1 to 1.5 millimeters of bone on either side of that implant that you're placing. If you don't, that's when you perform alveoplasty. That alveoplasty, though, should not be arbitrary, shouldn't be under-reduced, in which you are dealing with prosthetic space issues, or over-reduced, where you're taking away vital bone for future revisions if necessary. So you can have a bone reduction guide that's made to reduce exactly what you need. After that, you will look at the bone height remaining. If the bone height remaining is sufficient, that's when you go to an FP2, elongated crown case, or FP3 approach. If you don't have enough bone height, that's when you should be considered zygomatic approaches, pterygoid implants, or regeneration of the case in a horizontal fashion in order to get enough bone for placement of your implants. So let's look at this case next. So Melinda presented, like I said, with a number of mobile teeth in place. You can see here on the iOS scan. And at the time, we performed this case using the Straumann Smile in a Box protocol. So this involves a number of stackable guides that are placed in position, and these rest on the teeth initially, and a number of pins help to hold that base plate in place, onto which an osteotomy guide is placed and allows for implant planning in the exact position. A lot of these cases are done under deep sedation because of the length of the procedure, but also for comfort of our patient. Here we are doing a guided bone reduction protocol, and we go ahead and place our implants in the exact position that we want. These kinds of cases as well come with a temporary that is picked up in the mouth. It's based on the planned implant positions, and it's attached with temporary cylinders in place to those implant multi-unit abutments you've attached in the mouth. So the outcome for this case was very favorable. We ended up doing the top and bottom under deep sedation for the patient. And this is a typical hybrid case, an FP3 approach on a patient that is missing bone, volume, and her crowns are immobile. But what about young patients? Patients such as Mark. So you can see here, Mark, when he smiles, he has a very high smile line. He has a number of decayed teeth, but he's not a periodontally diseased patient. So in this case, you need to look at that smile line. So this goes back again to high-end photographs for treatment planning of your case. And for Mark, we're dealing with the transition zone challenge. What is possible for Mark? Well, one route you could go is with an FP1 approach, meaning you're doing a crown-only case. The aesthetics of that are going to be very challenging and the risks are higher. It's more for experienced clinicians. But given Mark is a young patient, I would be hesitant to go and cut almost 15 millimeters of bone away because of high lip line and transition issues. The other option is you can cut that bone away and go to a FP3 prosthesis. But for younger patients, I want to preserve what's there because implants are not necessarily forever. So FP1, we keep what's there. FP3, we go and remove that bone and hide that transition zone below the lip line. So what's possible? And I think it's important to understand that it always begins with diagnosis of your case. So for patients that have a very high smile, such as this is an edentulous case, that bone for sure has to be taken away. Because you don't want to end up like this. This is a picture sent from a colleague at Michigan. He's a prosthodontist there. And I had put this picture in one of our blogs called To FP1 or to FP3, that is the question. So I wrote this almost 4 years ago. It's been viewed over 28,000 times. Now that tells me either there's a lot of interest in this area of dentistry or that clinicians simply are not versed or well trained enough in this area, meaning that they're actively researching on how to improve this. So diagnosis of these cases is so critical to avoid complications. And complications in full arch can be even more challenging to deal with. Why? Because in single tooth implant dentistry, we're dealing with one tooth. For FP3, we have the challenge of taking out those teeth and then collapse and shrinkage of all those areas. For single tooth implant dentistry, you have at least the neighboring teeth that are holding the bite in place and keeping that architecture of the site in place. So in our saving grace, essentially in single tooth implant dentistry is that adjacent tooth and its PDL. And these are complications that could potentially happen. What now in a case like this? Luckily, this is underneath the patient's lip line, but what you have to do is rely on tissue grafting techniques to hopefully mask and protect that exposure of implant components. So long-term remodeling can involve tissue retraction, pigmentation, tissue depression. Sometimes it's peri-implantitis. So a patient of mine I saw had a failed block graft, lower left, had peri-implant disease on the lower right implants, probably done as immediates a number of years ago. In this case, all we can do is remove everything. But as a consequence, when you remove everything, place further implants, you end up with a very thick prosthesis. It's very tall. This is what I call last chance dentistry. There will be no further bone to potentially go into if these implants end up failing. So understand that implants are not forever. Sometimes we're using tissue as a solution to mask that implant exposure. But understanding why that remodeling happens is important to understand in full arch planning. Another example of mine, we have some exposure at 5 years of those multi-unit abutments. We have to deal with that using tissue techniques. A free gingival graft is harvested and will protect hopefully that area for a long time. Here's another case of mine from a patient that had implants placed over 15 years ago. Now the implants have discharge, pain, and discomfort. When we open the area up, you can see the implants have no bone around them. Likely again done as immediates a number of years ago. Obviously these implants weren't placed at this level, but as a consequence of that bone loss and remodeling, you do end up with removal and having to deal with implants now that are of an extramaxillary region placement and more complex and costly procedures for our patients. So for us, we need to keep the good and get rid of the bad. So in medicine, we don't go and pull an organ because a simple part of it is disease. We end up taking away the unhealthy part and keeping the healthy part if we can. And endodontists know this very well. They are performing apicectomies, sometimes root resections, although not done as commonly nowadays with implants being more and more favorable. But the goal is being the same: remove the bad and keep the good. In 2023, we wrote about partial extraction therapy concepts, applications in full arch, in a 2-part series. Part 1 dealt with applications of that technique. Part 2 dealt with complication management. So these articles are available on our website if you want to read further into it. Essentially, socket shield technique, although an amazing technique, still has some drawbacks. Now for me, these are manageable complications though. So I don't consider these as complete failures. So for example, internal shield exposures are very minor complications. They're dealt with either trimming down that exposure and covering it with tissue, or allowing tissue to grow over top of that exposure and adjusting the shape of your temporary to allow for that blood clot and tissue to fill that space. Here we are in this case with total resolution of that exposure, and patient now goes to their final prosthesis. External shield exposures are often caused by pressure. This is a case from Dr. Campos, in which the exposures are caused by friction from the denture in place. In that case, that's trimmed down, tissues repositioned. And very rare, shield mobility, which is caused by having implants that are placed with shields that are simply too short or basically too thin. So in these kinds of cases going forward, we've developed protocols of minimum height of 7 to 8 millimeters to avoid problems of shield mobility, but also ensuring your shield is not too thin, so that it does not have the chance to crack or flex with time and cause mobility as well. So in this case, contributed by Dr. Luckman, he ended up removing the shield. The implant was osseointegrated, and he was able to still keep the implant. So let's look at case 2, decay and wear. So on Mark, when we take a picture, we can see that Mark is a decay and wear patient. We need to look again at lip line and gingival display. For Mark, lip line and gingival display is high. We need to perform alveoplasty in order to correct that. However, before we jump to removal of all the teeth, we need to consider, can we keep some elements of his dentition, knowing that resorption is going to happen in the long term, such as what I've shown. So 7 to 8 millimeters of teeth height remain after planned bone reduction. We can perform a crown lengthening around those teeth instead of total alveoplasty, and go with an FP1 approach with partial extraction therapy. So let's dig into that deeper. So again, we go ahead and perform smile cloud analysis on our patient. This is not only a helpful motivator tool for patients to see before and after, but helps with our planning for our cases. Some of the concepts you'll see in this case date back to the PSI concept from 2019 under the Salama group. And the PSI concept involves partial extraction therapy and scallop guides in order to have a scalloped bone development of the case. So for Mark, we go ahead and import his case into our exocad design software at our laboratory and team. We perform a crown lengthening mock-up for the case. And for his case, we have an overlay now of the design and then implant planning positions. Afterwards, we have our developed implant plan according to that prosthetically driven implant position. Next, we have our laboratory perform two things: crown lengthening guide and then a set of guides for anterior implant placement and posterior implant placement. Before we jump to pull out all the teeth though, we take advantage of the fact that he has teeth. Teeth supported guides are the most stable, meaning that we have those guides sitting on teeth that are going to be potentially removed, but using them as supports for those guides. Once those teeth are removed, then we can go ahead and place implants in those positions if necessary. So here's Mark with his pre-op position. We go ahead and perform socket shield therapy to the planned crown lengthening positioning. Here's a socket shield preparation. And we have our guides, anterior guide and posterior guides, to have our implants exactly where we have planned them. Now, if the implants are stable enough, on the day of the surgery, we end up doing a pickup. So what we use in our practice now is photogrammetry. So we use the iMetric 4D system for the last 5 years with amazing success. Why? It allows me to have a same-day temporization with high accuracy. So for full arch, where are we now in terms of digital workflow? We're relying on capture of the data on the day of the surgery and 3D printing on the day of the same day as the surgery. For us though, I don't think that digital scanning alone is sufficient in order to capture that data. You have stitching challenges in terms of data capture. So you're dealing with a bloody field. You're also dealing with scan body geometry and library. If they're too tall, then your scanner could have potential hard time to pick up those scan bodies. You're also dealing with distances between hard points, meaning that if you have a very long distance, your scanner could have stitching errors. And that gets magnified, especially in edentulous free end cases. So magnifying that error across 4, 5, 6 implants could lead to misfit of your case on the final. Your temporary might fit because it can flex into place, but your zirconia could end up fracturing, and I've seen it happen in clinical practice. So in 2022, I wrote about a digital approach to loading of your cases, and this is again available on our website. So our approaches involve keeping teeth either as reference markers, and those teeth get removed at the end of the surgery, or alternatively, if there are no reference markers you can use as teeth, then we rely on screws. These screws are placed either in the palate or they're placed in the chin area of the mandible. As an example here, we're using the arch tracer screws. These get placed at the start of your surgery, at which point an intraoral scan is performed and stays throughout the surgery. Now, this provides a consistent reference marker that allows you to take your surgery, midpoint, and endpoint to the same referencing position for your data to stack together in your design software. For Mark, we're able to do a same-day temp insert. This is printed same day. 3 months later, you can see abundant, robust, healthy tissue on first disconnect of your temporary. We finished the case for Mark in monolithic FP1 zirconia with Mio liquid ceramic staining. And this is how we finish his case. We didn't have to go cut away all that bone. You can see the change in his face and his eyes simply from having that rejuvenated smile and given a second chance again at having confidence back in his life. The last case I want to discuss with you is Angela. So Angela is in a similar situation as Mark, however she has a low smile line. So for her, we go through the same full arch algorithm workup. We have decay wear. We have, in this case, low smile line, which is favorable for us. But don't get deceived thinking that low smile line meaning sufficient prosthetic space, because you need to respect the space requirements for the materials that you use, meaning that you have to have at least 8 to 11 millimeters, and I would say more closer to 11 millimeters of vertical space for the zirconia prosthesis that you place. Next, we need to look at if opening of the vertical dimensions indicated. In her case, it was not. We're keeping her at the same VD. Since we are not opening her VD, we can proceed with an FP1 approach with partial extraction therapy. We bring in her smile into our design software. We go ahead with a guided socket shield approach, and osteotomy guides are fabricated. Here's our proposed plan. We have our implants in position. And we go ahead and take advantage of digital dentistry. We have a guided socket shield guide. This allows us to core out those socket shields right to the apex, which tends to be the most difficult part of the procedure. And then we go ahead with implant placement. Same day, we pick up her records using our iMetric system. Same day temp insert again. And here's the patient in the temp stage. 3 months later, temp is removed. Patient now is going to have potentially a second or third temp to optimize the shape and size of her teeth. You can see here we have abundant, robust tissue, no collapse or loss of volume of tissue. We finish the case again in monolithic zirconia with liquid ceramic staining at our lab. And final tissue shaping. Most important to see here is that tissue has now pseudopapilla. We're able to develop that tissue to create something that is very aesthetic without loss and collapse of tissue, and not having to resort to bone from a bottle, having to resort to tissue grafting, to synthetic products. You were just using what the patient has come in with. Final insert of the case for the patient. And patient here was thrilled with the result here. So to conclude this presentation, I want to focus on a few key points. Number one, understand digital dentistry can help maximize the aesthetics of your cases. Secondly, proper communication with the lab. You need to understand, is this a good lab? If not, find a lab that's done this many times. Our lab is led by us as dentists. We can help plan your cases because we've been through those positions many of times. Finally, looking at preservation approaches, partial extraction therapy, guided approaches. Why? These can potentially minimize complications for your patients. It's been my pleasure to record this presentation for everybody here. I hope you get a lot out of it. If you're interested to learn more about these kinds of applications, feel free to reach me at our email here, info@cdnimplants, or give me a shout on Instagram.